If you've been told you might be a candidate for lumbar endoscopic spine surgery, you're probably trying to decode what that phrase actually means. Not whether it works for you or should you do it, but what it even is. We're talking about your lower back, lumbar spine. The real question most people are thinking is, are they talking about cutting my spine open? Or is this something different? Normal anatomy. So let's start with what your lower back normally does. The lumbar spine bears most of the weight of the upper body and allows you to bend, sit, twist, and stand back up. On the outside are layers of muscle that control motion and help keep you stable as you move. Underneath are rows of bones called vertebrae, which you can think of as sturdy blocks stacked up on top of each other. Between the blocks are discs. These are tough but flexible spacers that allow movement while distributing the weight of the upper body. Behind the disc is the spinal canal, a protected tunnel that carries the nerves traveling down to your legs. Each nerve exits through a side opening between the bones, and when that space is roomy enough, the nerves slide and glide without complaint. Every part here has a job. Muscles move, bones carry weight, discs allow motion, openings create space. Nothing here is supposed to be perfectly still, because movement is in the design. What has changed? When lumbar problems come up, it's usually because space, motion, or load has changed. Your bones are still bones, your nerves are still nerves, the spine hasn't suddenly become fragile. What tends to change is how much room is available. A disc may bulge backward a bit, or a joint may thicken over time, or a ligament may stiffen. None of that automatically means, quote, damage. It just means the shape of the tunnel or opening isn't what it used to be. As space narrows, motion changes. Nerves that once slid freely can get crowded during certain movements, and pressure that used to spread out may start focusing in one area. That's why symptoms tend to appear with specific positions like standing, walking, sitting, or twisting. The system still works, it just has less room to adapt. Symptoms and tests in context. Confusion usually starts after symptoms show up, but before anything is explained. You notice leg pain, numbness, or a burning sensation that comes and goes. Maybe weakness that's better some days and worse on others. So the next step is usually imaging, an x-ray, an MRI, sometimes a CT scan. When the report comes back, it's full of big medical words like compression, stenosis, and disc protrusion. These words describe anatomy, what doctors see on the image, not how severe your symptoms are or how they change from day to day. And that's why what doctors see on a scan doesn't always match how you feel. Some people have scans that look dramatic but feel relatively okay, while others are in a lot of pain even though the images look subtle. Think of the scan as a map, and your symptoms are the traffic on that map. Your doctor needs both to understand what's really happening to you, and neither one tells the whole story on its own. This kind of mismatch is very common, and it's a big reason medical and surgical reports can sound alarming before someone sits down and explains what those words actually mean for you. Positional symptoms, such as worsening pain with standing or walking, and relief when sitting or bending forward, are characteristic of lumbar spinal stenosis due to posture-dependent changes in canal dimensions. What different treatment approaches change mechanically? When people start talking about endoscopic spine surgery, the first step is making sure you understand what it is and what it isn't. Doctors usually start with more conservative options, things like exercise, injections, or changing how you move day to day. Note that these approaches don't change your anatomy. They just change how stress and motion move through your spine. Procedures in surgery are different from exercises or injections. Instead of changing how the spine moves, they work by changing how much space a nerve has. In traditional open surgery, the surgeon needs a clear line of sight. That means moving muscle aside to directly access the bone or disc and create more room for the nerve. Endoscopic surgery works a little bit differently with the same goal in mind. Instead of a larger opening, surgeons use a small tube with a camera and instruments to reach the problem area. Questions to take to your doctor. When this term comes up, it can help to pause and ask a few clarifying questions. These questions are about choosing a procedure. They're about you understanding the map before you decide where to go. How does the space around my nerve change with different positions in daily life? Or, on my scan, which structure is actually closest to the nerve? If parts of this felt slow or dense, that's okay. Come back to it when you need to. The point isn't to decide anything today, it's to recognize the words when they come up later. If you think this would help a friend or family member make sense of a similar conversation, please feel free to share it with them. This has been the Brit Factor with Bonafide, and thank you for learning with me.